Hello, students. Good morning. Today, in this session, we'll be discussing about pharmacotherapy of cardiac arrhythmias. Myself, Sudhir Prudhvi. So let's start our discussion now. So before going to talk about arrhythmias and drugs for arrhythmias, let me tell you a simple introduction about a conducting system of heart. So how does this conduction starts and how it proceeds and how it ends? This is what like normal impulse conduction. It starts from sinoatrial node, and next it passes to atrioventricular node. Next it goes to bundle of His, and next bundle branches and Purkinje fibers. Right. So this is what the normal conduction system of the heart is, starting with the sinoatrial node and ending with the Purkinje fibers. Right. So what is the definition of arrhythmias? So arrhythmias are deviations from, they are the deviations from normal pattern of cardiac rhythm, which includes abnormalities in impulse formation and abnormalities in impulse conduction. So there are some abnormalities in both formation as well as conduction. So that is for the arrhythmias. So what are arrhythmias? Arrhythmias are deviations from normal pattern of cardiac rhythm, which includes abnormalities in impulse formation and abnormalities in impulse conduction. So what are the abnormalities in impulse formation? It includes rate, rhythm, and the site of impulse origin. In abnormalities of impulse conduction, it includes disruption of normal sequence of atria and ventricular depolarization. So this is what the arrhythmias means, right? So in simple, they are the deviations from normal pattern of cardiac rhythm. So let me tell you a small thing about action potential of cardiac myocyte. So it includes 4 phases: phase 0, phase 1, phase 2, phase 3, and phase 4. So what are these phase 0, 1, 2, 3, 4, and what happens in those 4 phases? All those things we'll be discussing in our next slide. Because if you want to understand a concept about antiarrhythmic drugs, we should have a clear idea about this action potential. You might have learned this one in your physiology, but here I will just give a rapid brush up. Okay. So what is this phase 0, phase 1, all those things means? Phase 0. This phase 0 is also known as rapid depolarization phase. So what is this rapid depolarization phase? Rapid depolarization. So what happens in this phase 0? Sodium channels are getting opened. So what happens if sodium channels are getting open? So before going to this phase 0, I just want to give a small thing. The resting membrane potential of cardiac myocyte is minus 90 millivolts. That is what this one, like minus 90. It is staying in minus 90 itself until the action potential comes. When the action potential comes, when the threshold value is reached, definitely the sodium channels are getting open. When the sodium channels are getting open, the ion movement, the sodium channels, through sodium channels, the sodium ions, it moves from outside to inside. That is what I wrote there, outside to inside. What happens if a sodium ions moves from outside to inside? So this negative charge, this minus 90, it comes up to like plus 30, plus 80, roughly, or plus 80 or plus 50. So it minus from minus 90, it comes to positive charge. Okay. So this is what the rapid depolarization. It stops when this phase 0 stops. This phase 0 stops when the sodium channels are closed. So here the sodium channels are closed and phase 0 stops. And the next phase 1. In phase 1, sodium channels are closed. We know that sodium channels are closed, and here again potassium channels are open. So what happens if potassium channels open? Means the ion movement from inside to outside. Potassium channel ion movement, it goes from inside to outside. So obviously inside there is positive charge, For suppose the positive ions left from inside, what happens? The positive charge come to, it decreases. So it may come to 0, it may go to negative even. Finally, the ultimate thing is it is getting decreased. So that is what the phase 1. And here the phase 1 finished. And phase 2, the name for this phase 1 is early repolarization. This one is rapid depolarization. This is the early part of repolarization. And phase 2 name is plateau stage. Just like a plateau. So here L-type calcium channel open and potassium channels are opening. We know wherever potassium channel opens, the movement is inside to outside only. Potassium channel means inside to outside. So here in phase 2, calcium channels also opening. Here outside to inside, calcium ions are moving. So here you see calcium ions are moving from outside to inside. Potassium ions are moving from inside to outside. So what happens? It is getting balanced. For every one calcium ion coming inside, 2 potassium goes outside. So they are getting balanced. So that's why this phase remains in plateau stage. And coming to phase 3, here L-type calcium channel closes and potassium channel is remain opened. So ion channels move from inside to outside. So from 0 to it comes to -80. And in phase 4, it is a resting membrane potential. And phase 3 is rapid repolarization. Rapid repolarization. Phase 0 is rapid depolarization. Phase 1 is early repolarization. It is plateau. This is rapid repolarization. And phase 4 is resting membrane potential. So here resting membrane potential, it maintains at -90. So how it is maintaining at -90? With the help of sodium potassium ATPase pump and potassium outflow and sodium calcium exchange. So this resting membrane potential, it maintains cardiac myocyte action potential, membrane potential at -90 millivolts, -80 to -90 millivolts. This is what a small brief thing about this cardiac myocyte action potential. So here what I told, so phases and what happens in those phases, and ion movement, whether it is moving from inside to outside or from outside to inside, and how the membrane potential is getting changed. And this is a very important box. If suppose if you get a question like cardiac action potential or cardiac myocyte action potential or ventricular action potential, you can just write this table and this graph. Okay. So these were the same thing which I explained. And here I want to give a small I want to give a small concept regarding refractory period. Refractory period. So here in cardiac myocyte refractory period, there are 3 types: absolute refractory period, relative refractory period, effective or total refractory period. Okay, absolute and relative and effective. Effective refractory period also known as total refractory period. So what is refractory period? It is a period where the other this action potential or this cardiac myocyte, it remains calm. Even if another action potential comes, it doesn't generate that action. It doesn't generate that impulse. That is what the refractory period means. So it is divided into 3 types, I told, right? So what is absolute refractory period? Starting from 0 up to mid of phase 3 is absolute refractory period. This is absolute refractory period. And from remaining half of third phase to resting membrane potential, this is known as effective refractory period. Sorry, a relative refractory period. Combination of those two is known as total or effective refractory period. So absolute refractory period means from phase 0 to half of phase 3, that is midpoint of rapid depolarization, and the remaining half of the rapid depolarization is relative refractory period, and combination of these two is total refractory period. Okay, combination of absolute and relative is effective refractory period. So here in absolute refractory period, even if another action potential comes, it doesn't generate that one. In relative refractory period, if action potential is stronger than the first one, it may generate. That is what the thing. Okay. So three refractory periods: absolute, relative, and effective. Right. So now a small thing about ECG. This one you might have known what is ECG and what are those waves. P wave, QRS complex, T wave. So P wave is nothing but atrial depolarization, and QRS complex is nothing but ventricular depolarization, and T wave is nothing but ventricular repolarization. That is nothing but this is just a small thing about this cardiac arrhythmias. ECG. So coming to genesis of cardiac arrhythmias, you need not to know in detail about the genesis of cardiac arrhythmias. Just to remember the names. That's it. So what are the genesis regarding genesis of cardiac arrhythmias? It has three things: abnormal impulse generation, triggered activity, and abnormal impulse conduction. In triggered activity is also known as after depolarization. It includes delayed after depolarization and early after depolarization. And in abnormal impulse conduction, it includes three things again: conduction block, re-entry phenomenon, and accessory tract pathways. These are the reasons why arrhythmias are getting generated and patient is getting suffered. Okay. So just remember these points like 1, 2, 3 points, and second and third points have another sub points. You just remember the names. That's it. You need not to know in detail about all those triggered activity or delayed after depolarization or re-entry phenomenon. You need not to know all those things. Just remember the names as of now. So coming to antiarrhythmic drugs. So coming to antiarrhythmic drugs, this classification it has specific name, Von William classification. So suppose if they ask in exam just one William classification, if they ask about antiarrhythmics, you will write. Suppose if they are one William classification, then also you have to write antiarrhythmic drugs, and this is important one. Okay, just remember the names. It has 4 classes: class 1, class 2, class 3, class 4. And class 1 it includes sodium channel blockers, class 2 includes beta blockers, class 3 includes potassium channel blockers, and class 4 includes calcium channel blockers. And you just remember the drugs here. These are, of course, I can understand these are a bit difficult, but if you read like 4 or 5 times, definitely you can remember these drugs. Again, this class 1 is divided into class 1A, 1B, 1C. 1A drugs includes quinidine, disopyramide, procainamide. Quinidine, disopyramide, procainamide. And 1B includes lidocaine or lignocaine, phenytoin, mexiletine. So 1B includes lidocaine, phenytoin, mexiletine. Class 1C, it includes flecainate, propafenone. Class 1C includes flecainate, propafenone. And then 2 beta blockers. You might have known about these beta blockers in adrenergic system. Propranolol end with LOL, LOL. Ending with LOL, it is a beta blocker. Propranolol, esmolol, sotalol, metoprolol, all those things. Acebutolol, all those things comes under beta blockers. So potassium channel blockers, it includes amiodarone. This is an important drug, ma. This is a very, very, very important drug. If they ask anything about, if they are about to ask any question in antiarrhythmic drugs, this is what they are going to. Is a very, 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 very important amiodarone. Okay, and ibutilite, dofetilite, and dronadirone. So amiodarone, dronidarone, ibutilite, dofetilite. Okay, next calcium channel blockers, verapamil and diltiazem. So Von William classification of antiarrhythmics includes 4 classes: 1, 2, 3, and 4. Sodium channel blockers, beta blockers, potassium channel blockers, and calcium channel blockers. Again, one includes A, B, C. So these are the drugs. Okay. So now we will be discussing about each class. So coming to class 1A. So what is there in class 1A? You know, quinidine, disopyramide, and procainamide. So here, what happens in class 1A means it slow the rate of rise of phase 0. These are sodium channel blocker, you know. sodium channel blocker. So this black is a normal one. This red is a action potential of if we give this 1A drugs. Okay. So slow down the rate of rise of phase zero. This is a normal phase zero. Here it is getting slowed down. And obviously, I told you this total is effective refractory period. See here you see this red. Sorry, I will make it with yellow. It is fine. See here, this effective refractive period is getting increased, and action potential duration is also getting increased. Okay, and this repolarization, it is also getting increased. So that is what here which I meant. So slow down the rate of phase zero and prolong effective refractory period or total refractive period, prolong the action potential duration, prolong the repolarization. These are the properties of class 1A drugs, and this is the graph. So what are the therapeutic uses? First, we'll discuss therapeutic uses and we'll go to individual drugs. These are used to prevent these four. Okay, paroxysmal supraventricular tachycardia, used to prevent premature atrial contractions, premature ventricular contractions, and ventricular tachycardia. So coming to individual drugs, quinidine. So coming to quinidine, what are the ADRs? You know, uses those four. And coming to ADRs, diarrhea is the most common ADR for quinidine. And other ADRs includes quinidine syncope and synchronism. This synchronism includes tinnitus, headache, vertigo, blurred vision. Okay, these are the ADRs for quinidine. And what are the contraindications for quinidine? These contraindications you can remember with the mnemonic A, B, C, D, E. Quinidine contraindications: AV block, CHF, digitalis intoxication, embolism, AV block, CHF, digitalis intoxication, that is digitalis poisoning, embolism. So this is what with the quinidine. So quinidine, we know uses, and we know ADR, and we know contraindications. Suppose if they give a question about quinidine, you can write all those points. Okay. So you can just write these therapeutic uses for all class 1A drugs. It may be the quinidine, disopyramide, and procainamide. And these are what the ADRs, and diarrhea is the most common one. And contraindications you can remember with the mnemonic A, B, C, D, E. And coming to procainamide. Procainamide, you can write therapeutic uses, all those four: paroxysmal supraventricular tachycardia, premature atrial contractions, premature ventricular contractions, and ventricular tachycardia. And coming to ADRs, hypersensitivity reactions are most common. Quinidine, I told diarrhea, here hypersensitivity reactions, and systemic lupus erythematosus. And what are the contraindications? AV block and embolism. And procainamide, it has its metabolite. It is known as NAPA, N-acetyl procainamide. It is a class 3 drug. Okay. And coming to class 1B, it includes lignocaine or lidocaine, phenytoin, and mexiletine. And here what happens, what are the properties of phase 1B, class 1B drugs? It shortens the phase 3 repolarization. See, this is what the normal one, right? That is what the normal one. But see what happens here, it shortens. It came up to here only, this pink one. Okay, let me change color. It shortens the phase 3 repolarization, right? It decreases the effective refractive period and action potential duration. Obviously, it is getting decreased, right? So shortens the phase 3 repolarization and decreases the effective refractory period and action potential duration. What are the therapeutic uses here? Ventricular tachycardia, premature ventricular contractions, and ventricular extrasystoles. And this is what the graph for class 1B drugs. So coming to lidocaine, this is the most common local anesthetic. It is a drug of choice for ventricular arrhythmias due to digoxin toxicity. This is a drug of choice for ventricular arrhythmias due to digoxin toxicity. So what is the dose here? We have loading dose as well as maintenance dose. Loading dose 150 to 200 milligrams for the 15 minutes. Okay, 150 to 200 milligrams for 15 minutes, followed by 1 to 4 milligram per minute. Okay. What are the areas for lignocaine? Just confusion, convulsions, drowsiness, and slurred speech. So coming to phenytoin, it is the most common anti-epileptic drugs. It is used for ventricular arrhythmias due to digoxin toxicity. The same with lignocaine also. Use it for ventricular arrhythmias in children. This is a specific point here. Use it for ventricular arrhythmias in children. And what is the dose here? 100 milligram IV every 5 minutes until the arrhythmias disappear. Okay, until the arrhythmias disappear, and total dose is 700 milligram. It should not exceed 700 milligram. And coming to mexiletine, and it has a specific feature. It has no first pass metabolism. What are the indications of mexiletine? It is indicating chronic treatment of ventricular arrhythmias associated with previous MI and relief, and it has some other use, relief in diabetic neuropathy. So what are the ADRs? Tremors, hypotension, and bradycardia, decreased BP and decreased heart rate. What are the contraindications? AV block and cardiogenic shock are the contraindications. So here in mexiletine, we have indications, we have ADRs, and we have contraindications also. So it is indicated in chronic treatment of ventricular arrhythmias associated with previous EMI. Okay, it is associated with previous EMI. Relief in diabetic neuropathy even. And coming to ADS, decreased BP and decreased heart rate. Contraindications are AV block and cardiogenic shock. So here we finished class 1B drugs. Coming to class 1C drugs, it includes flecainide, propafenone. So here, what are the properties of class 1C drugs? So here you see, decrease the rate of phase 0 depolarization. This is for the normal one, and this red is the class 1C drug property. So decrease the rate of phase 0 depolarization. And coming to therapeutic uses, what are the therapeutic uses? These are used in premature ventricular contractions, ventricular tachycardia, which are refractory to other drugs. These two conditions, which are refractory to other drugs, we can use class 1C drugs. Coming to flecainide and enkainide, these are reserved for life-threatening refractory ventricular arrhythmias. I told refractory. Refractory means which are not responding to other drugs. These are reserved for life-threatening refractory ventricular arrhythmias. And this propafenone also reserved for life-threatening ventricular arrhythmias. So what are the ADRs? Visual disturbances, it's the most common one, and nausea as well as headache. And this propafenone is similar to propranolol. Propafenone, propranolol. So beta blocking action is also present here. This is just a small thing about class 1C. So here we finished this class 1C. So these are used for premature ventricular contractions and ventricular tachycardia refractory to other drugs. Okay, this flecainide, enkainide, and propafenone. So here we finished class 1E and coming to class 2, and we have class 2, 3, 4. And coming to class 2 drugs, it depresses phase 4 depolarization. As a result, it increases effective refractory period and action potential duration. The drug single I told class 2 is nothing but beta blockers. Beta blockers end with a lol, metoprolol, acebutolol, propranolol, esmolol. These are the 4 drugs which have anti-arrhythmic properties. And this esmolol, it has very short half-life, that is just 9 minutes. Okay. So now we will talk about these uses, therapeutic uses. So where these class 2 drugs are used. These class 2 drugs are used in supraventricular arrhythmias, that is atrial flutter and atrial fibrillation, tachyarrhythmias caused by adrenergic stimulation. So just adrenergic stimulation, if you give beta blockers, definitely they will get suppressed. And digitalis induced ventricular arrhythmias, atrial fibrillation, and Wolff-Parkinson-White syndrome. This is WPW syndrome, that is nothing but Wolff-Parkinson-White syndrome, where digitalis is contraindicated. So these are the uses of beta blockers. Suppose if they give class 2 antiarrhythmic drugs, you can just write those are beta blockers and write those names and write those 4 uses. Supraventricular arrhythmias, tachyarrhythmias caused by adrenergic stimulation, digitalis induced ventricular arrhythmias, atrial fibrillation, and Wolff-Parkinson-White syndrome, where digitalis is contraindicated. And what are the contraindications? So You might have seen my adrenergic system lecture. There I told beta blockers contraindications. Here I am just repeating again. What are the contraindications of beta blockers? AV block, bradycardia, cardiogenic shock. And one more, diabetes mellitus. I told A, B, C, D. Asthma, AV block, bradycardia, cardiogenic shock, and diabetes mellitus. These are the contraindications for beta blockers. So, okay. So class 2 drugs, if they ask about class 2 antiarrhythmics, just write the properties and just write the drugs and 4 therapeutic uses and 4 contraindications, that is A, B, C, D. AV block, bradycardia, cardiogenic shock, and diabetes mellitus. And coming to class 3 drugs, these class 3 drugs, what does it do? I told class 1, class 2, class 3, class 4. Block the sodium channels, block the beta, these are the beta blockers, these block the potassium channels, calcium channel blockers. So class 3 is potassium channel blockers. Block the potassium channels in phase 3. So what happens there? Prolonged repolarization. Prolonged repolarization at the same time, it increases the duration of effective refractive period and action potential duration without affecting phase 0. This is what the class 3 properties and drugs include. Dophytilite, beryllium, amiodarone. I told this is very important drug. Amiodarone and ibutylite. These are the 4 drugs: dophytilite, beryllium, amiodarone, and ibutylite. And you can remember these class 3 drugs with a small mnemonic. Dubai. Class 3 means Dubai. Dophytilite, D, dophytilite, okay, B, beryllium, A, amiodarone, I, ibutylite. Okay, you can remember these class 3 drugs with the help of mnemonic Dubai. So dophytilite, beryllium, amiodarone, and ibutylite. So these are the drugs. And coming to amiodarone. So remember, it is a iodine containing drug. It contains iodine. First point finished. And second point, it has broad spectrum of action. What do you mean by this broad spectrum of action? That means it possesses the properties of all 4 antiarrhythmic agents. That means it doesn't belong to class 3. It belongs to all classes. That means it has the properties of blocking sodium channels, blocking beta receptors, blocking potassium channels, and blocking calcium channels. It blocks every channel. Okay, sodium, potassium, calcium, and beta receptors. So it has broad spectrum of action. Where it is used? It is used for the treatment of ventricular fibrillations, ventricular tachycardia, and supraventricular arrhythmias like atrial fibrillations. So it is used for the treatment of ventricular fibrillations, ventricular tachycardia, and atrial fibrillations. And it has one important point: reduce the arrhythmic deaths in post-MI patients. It has important point, right? Reduce the arrhythmias deaths in post-MI patients. So here I do it is iodine containing drug. Suppose if anybody asks you in Viva, tell me the name of iodine containing drug. Tell me the name of iodine containing anti-arrhythmic drug. You can say amiodarone. Tell me, suppose if anyone asks you again, tell me a broad spectrum of action. Name the anti-arrhythmic drug which has broad spectrum of action. Amiodarone. So, which drug reduces arrhythmias death in post-MI patients? Amiodarone. These are the points for amiodarone, right? And coming to dose of amiodarone, it has oral dose and as well as IV dose. Oral dose 300 to 600 milligram per day. Coming to IV infusion, it has both loading dose 150 milligrams in 10 minutes, right? Followed by slow infusion 1 milligram minute for 6 hours. 1 milligram minute per 6 hours. Then coming to maintenance dose, here loading dose finished, coming to maintenance dose 0.5 milligram per minute for 24 hours. You have to remember this amiodarone IV infusion dose. It has both loading dose as well as maintenance dose. Loading dose is 150 milligrams in 10 minutes, followed by slow infusion of 1 milligram per minute for 6 hours. Okay, 1 milligram per minute means 1 milligram per minute. So for 1 minute we have 60. So 1 hour we have 60 minutes. So for 1 hour 60 milligrams will be given, 60 milligram per hour. That is for 6 hours. Into 6 means roughly we are going to give 360 milligrams in 6 hours. Okay, that is via slow infusion. That is what here. And followed by maintenance dose 0.5 milligram per minute for 24 hours. This is what the amiodarone dose. And coming to ADRs. So coming to ADRs, I told it contains iodine. So obviously hyperthyroidism, it may cause hypothyroidism also. So thyroid, hypothyroidism and hyperthyroidism. I, it causes corneal microdeposits and it has pulmonary toxicity. It produces hepatitis and increase LDL levels. So when you are giving amiodarone, you should be very cautious with these two things: corneal microdeposits and pulmonary toxicity. Okay, these are the ADRs. So here we finished this amiodarone. It is iodine containing drug. It has broad spectrum of action, that is class 1, class 2, class 3, class 4 properties. It is used for the treatment of ventricular fibrillations, ventricular tachycardia, and atrial fibrillations. It reduces arrhythmias, deaths in post-MI patients. What coming to the doses? Does oral dose and as well as IV dose, IV loading dose as well as maintenance dose, and ADRs. In those ADRs, we have important corneal microdeposits and pulmonary toxicity. And coming to dofetilide and ibutilide. So dofetilide, where we use that? Dofetilide use it for atrial flutter and atrial fibrillations. Ibutilide, we are rarely using that one now. What are the ADRs? ADRs, QT prolongation and tortuosity point is, and what are the contraindications? Hypokalemia and hypomagnesemia. These are just the points where we use ADR and contraindications. Finished. Dofetilide and ibutilide. And coming to class 4 drugs. Class 4 drugs, these are the calcium channel blockers. Decrease the phase 4 depolarization. It prolongs the action potential duration as well as absolute refractory period. Slow down the rise of phase 0. See here, this red one, slow down the rise of phase 0, and phase 4 decreases phase 4 depolarization. And what are the drugs here? Verapamil and diltiazem. And where we use these class 4 agents? These are mainly used for uh, paroxysmal supraventricular tachycardia and control the ventricular rate in atrial flutter and atrial fibrillation. And here we have separate doses even. In paroxysmal supraventricular tachycardia and atrial arrhythmias, in paroxysmal supraventricular tachycardia and atrial arrhythmias. So what is the doses? Verapamil 80 to 120 milligram TID, here 30 to 60 milligram QID. And coming to atrial arrhythmias, 5 to 10 milligram per hour IV, 5 to 50 milligram per hour IV. Suppose if they ask class 4 antiarrhythmic drugs, you can just write class 4, these are the properties and these are the drugs. You can draw the graph and you can write where we use these drugs, that is paroxysmal supraventricular tachycardia, that is PSVT, and atrial arrhythmias, and these are the doses. And what are the ADRs now? Peripheral edema, lethargy, and constipation. This constipation is only with verapamil, not with the diltiazem. And what are the contraindications of these things? AV block, congestive heart failure, Wolff Parkinson White syndrome, and sick sinus syndrome. Okay, these are the ADRs and contraindications. And we have other drugs. It doesn't fit into those four classes, that is adenosine and magnesium. Where we use adenosine, it is a drug of choice for paroxysmal supraventricular tachycardia. It is a very, very, very short acting drug, that is half-life is just 10 seconds. And what are the ADRs? Flushing and bronchospasm. So because this drug acts only for a short span of time, so these ADRs also the ADRs also have very short action. Sorry, they live for a short period of time. And coming to magnesium, it is used to treat congenital and acquired long QT syndrome. So if anybody asks what is the role of magnesium in arrhythmias, you can just write congenital and acquired long QT syndrome. And this one you can just, it is just like a rapid glimpse. Classification of drugs, mechanism of action, and what are the comments, the I told properties, right? It slow down the phase 0, shortens the phase 3, shortens the phase 0, like all those things. You can just make it like a tabular column. And this is a small homework for you. I told many graphs regarding 1A, 1B, 1C, 2, 3, 4. And this first graph, upon seeing the graph, can you tell it belongs to which class? This drug belongs to which class? And this class, I mean, this second picture also. Can anyone comment down the answer? And those who uh, comment correctly, uh, they will get a nice gift when they nice prize um, when they come to when you people come to these offline classes. So these are the two graphs, first graph and second graph. If you want, you can just rewind the lecture, and again, if you can see those graphs, and you can comment down the answer. Okay. So this is what this anti-arrhythmics today session. Today completely we covered all those anti-arrhythmic drugs, that is von William classification. And I told in those drugs, the most important thing is amiodarone. Okay, that's the most important one. And if anybody asks you, suppose just write beta blockers, anti-arrhythmic action of beta blockers, you can just write those. And for every classification, you have only these things. Number one, writing down the properties and just drawing the graph. What are the therapeutic uses and what are the drugs and therapeutic uses, ADRs and contraindications. Okay, if you can just make one tabular column, big tabular column, that will be very useful for you just before going the exam, just like a rapid glimpse. Okay, so these are the things which we covered today. And I told I am stressing amiodarone. Okay, so class 4 verapamil diltiazem, ADRs, and these are the other drugs, just like a rapid glimpse. And these are the questions, and I want majority of the people to answer this question. Thank you.